Facial cancer attending to audible. And so by way of introduction, oral and maxillofacial cancers, oral cancers, and head cancers, which are used interchangeably, are a heterogeneous group of neoplasms affecting structures of the head and neck, especially the lips, oral cavity, salivary gland, the jaws, face, and the neck. It's relatively common, with an estimated 200,000 deaths annually from the 2018 estimates. In Nigeria, the burden is relatively high, even though it's not accurately defined. Treatment, of course, we know involves early surgical treatment, use of radiotherapy and chemotherapy, and of course, follow-up. Adherence principle is important for good outcome and survival. So, the term that is used to classify patients in a clinical care program. So, this patient, they come seeking care, but after a while, I'm not talking about patients that had treatment, had surgery done, but these are patients that came to us and they just disappeared. So we needed to know what happened to them. The aim of study is to establish proportion of patients lost to follow-up and identify reason for loss to follow-up of these patients. Methodology is a cross-sectional study. So we took histologically confirmed cases of oral and maxillofacial cancer cases between January 1st and 2010 and December 31st, 2020. So the information we gathered, we took locator information, phone calls, addresses of these patients, and the trained research assistants that have done this kind of tracing were used to trace the patients. So phone calls were the first, was first of all used. Then after the phone calls, we had their consent to participate. Those that could not be interviewed with the phone, or maybe we could not get the phone number, we also use the addresses, home addresses, or any address that was in the case notes, and we used that to trace them. So those that were successfully traced, we administered a questionnaire to find out the predictors of loss to follow-up and the reasons why they have not been followed up. The study was approved by the Lagos University Teaching Hospital Human Research Ethics Committee. So this is a flowchart depicting what we did. So patients in our population, in the case from our records, about 315 patients. So from there, about 102 were confirmed to have been surgically treated. Then suspected loss to follow-up, 213. So we traced some of them. We successfully traced 65 out of the 213. And out of these 65 that were just successfully traced, 20 were alive and 45 dead, and we could only interview successfully 16 patients. This is a table showing the baseline characteristics of the patients. This is for all the patients, the ones we tracked and the ones we couldn't track, then the ones we actually traced and the ones we couldn't trace, and the ones that are alive and those that are passed away. Importantly, well, even though this the sample is quite small, but these were the patients that we could actually interview, and the reasons why they disappeared or they were lost to follow up. These were some of the reasons. 4 of them said they started treatment in another clinic. Some said high cost of treatment. Some said poor attention, and one had felt he was feeling healthy and there was no need for treatment. So discussion, we have, this study showed a high proportion of loss to follow up. That's about 67, just above 67%. And this is higher than the acceptable rate of 15%. About half of the patients that we also try to trace could not be accessed. So at present, access to patient health data for cancer research is difficult, and access routes are variable and complex to navigate. And this can serve as a barrier to the application and to determine cancer survival in this group of patients. Then more than for those that were successfully traced had also passed away. And by passing away, some of them did not even receive treatment before they passed away. The reason for the lost follow-up from the small population accessed were patients, they went elsewhere, poor engagement modalities that require repeated visits, traveling long distances, and significant delays in care. We should know that for cancer patients, there is often the need for them to come to the clinic severally, and this can be a bit tiring for this group of patients. And some of them have to travel long distances because the centers that take care of cancer patients are often located in the big cities, in the tertiary institutions, and they have to travel from long distances to see this, to access care. So facilities with a high follow-up could malign the predictors of cancer survival, meaning that if we have all high loss to follow up in care or in some facilities, it will be difficult to determine the predictors of cancer survival. So by conclusion, a relatively large number of patients seen initially in our clinic were lost to follow up. Follow-up records were outdated, and loss to follow-up can be worsened by poor attention from the clinic and high cost of surgery. We are recommending that we incorporate loss to follow-up tracing programs in cancer care. We also need to improve the skill of the workforce to collect high-quality data. We don't want data, I mean, we look at some of the records, they are not complete. Some don't have addresses, some don't have phone numbers. So we need to make sure that complete data is collected. Data, including those lost to follow up, must be routinely digitized. There is the FAIR acronym, digitized, findable, accessible, erasable. So that is how we should use it. And we can do this and improve this by using routine mobile phone calls for monitoring, and all and other modern treatments. So also research innovative ways to re-engage patients back into care. And of course, also very important, policy and advocacy for reduced cost of cancer care is required. These are my references. Thank you. Hello? Hello?
Hello?
Yes.
Thank you very much, Abdul. Rogathe, are you there?
Hello. Oh, thank you, Abdul, for your nice presentation. You really keep time, and since we have gathered that the question will be answered at the end, so maybe you can continue checking on the chat box in case of any question that the member will be dropping there. You can respond. However, we'll be having 2 minutes at the end to respond on the question. So thank you so much, Abdul. So no may problem. I move to, if thank Musa you. Is in now.
Yes,
Hey,
I
Musa,
am.
you are.
Hello.
So
Yes, I am.
please.
Okay. Can you see my slides? I shared poster.
Yes.
Is in my poster? I shared a poster now. Is it showing on your screen?
Sanusi Musa, are you able to present?
Yes.
Are you able to share your screen?
I am sharing. I don't know whether you are seeing my
You have
screen.
been given rights to share your screen, so you are able to do so.
Are you seeing my screen? Because I
Not
shared
yet.
now. Okay, please share the one I sent you, because this one, since you can't see my own. So I'm trying to share it, it's not showing. Oh, that's from my system.
Maybe technical moderators can assist us, can assist Musa if
Yes, the one I
it's
shared.
within your capacity.
You can present the one, because I'm trying to share my screen. It's not showing. I'm on screen share, but
So because of time, can we move to another presenter while we are figuring out how to share the screen, Musa?
okay, okay.
It has already been shared.
Already shared? Okay. Okay, good day to all participants. My name is Sanusi Musa. I work at Ahmadu Bello University, Zaria, and also a student at University of Benin City, Nigeria. I'm to present a poster on adherence to universal basic precautions among hematology staff of Usmanu University Teaching Hospital, Sokoto. First of all, universal basic precautions, according to United States Center for Disease Control and Prevention, it was described as a set of precautions or actions designed to prevent transmission of HIV, hepatitis B virus, hepatitis C virus, and other body fluids, blood-borne pathogens when giving first aid or health care. The aim of this our study is to look at the attitude, practice, and level of adherence to universal basic precautions among 43 staff of hematology laboratory, Usmanu University Teaching Hospital, Sokoto. And the 43 staff were recruited after getting ethics clearance from ethics committee of Sokoto. The information was questionnaire. It indicates that more than 70% of the staff working at hematology laboratory were not vaccinated against hepatitis B virus, even though they are still working in the lab. And a good percentage of them, like more about 30%, didn't receive any training on laboratory safety, which we attribute to lack of policy on laboratory safety in that particular laboratory. And concerning the practice of safety, adherence to safety about 11 of the staff in the world are well there in the lab, making 69% do not wear face masks well in the lab, and 11.6% do not use laboratory coats while they are in the lab. And issue of blood splash was recorded in 53.5% of the staff, and likewise, needle stick injury was recorded among 79% of the staff. But only 13 out of the 34 went for testing of the patient's specimen to confirm it if it has body blood pathogens. And likewise, out of the 10 that sustained, out of the number that sustained needle stick injury 9, only 2 of them went for post-exposure prophylaxis. So, based on this our study, we found out there is suboptimal adherence to universal precautions among hematology staff in Usmanu University, Sokoto, and we recommend to the hospital for the creation of occupational health occupational health department, so that anyone with the issue of needle stick can be referred to such department to assess post-exposure prophylaxis. So conclusively, as I said, we observe suboptimal adherence to universal basic precautions among hematology staff. These are some of my cited references. Thank you for listening.
Thank you, Musa, for your nice presentation. Well presented, and I think members have taken the point that they think they can assist them during their professional implementation. So may I welcome Solomon, if already in?
Yes, I'm here.
Okay, Solomon, you're welcome. The floor is yours.
Okay, let me enlarge the screen. Can you see the enlarged screen, Frank?
Yeah, you can enlarge more.
Hello?
More. Yeah, yes, at least there is fine. Yeah, it's fine now.
Okay. Okay. So good afternoon, colleagues. My name is Pule Solomon Moabi. I'm a nurse midwife by profession, and I'm currently working at a nursing college in Lesotho. And this paper has been prepared by myself and Professor Gloria Msali, who is a professor in the University of KwaZulu-Natal, South Africa. We are going to present about nursing education institutions' readiness to fully implement simulation-based education in Lesotho. So, in our background, we know that the use of simulation is gaining momentum in our nursing education institutions because we want to have competent graduates that will be able to provide competent nursing care. And the simulation laboratories, known as the skills laboratories, need to be manned up by the human resources. And those human resources must be qualified so that they can create enabling environment. But then, in Lesotho's context, there are various challenges to the implementation of simulation-based education. For instance, within their simulation laboratories, they used improvised equipment and supplies. And also the mannequins, the high fidelity mannequins and the medium fidelity mannequins, they are fixed after a long time because they don't have the capacity to fix the mannequins as they take the mannequins to the neighboring country, South Africa, to be fixed. And also the simulation laboratories are manned by educators who also conduct clinical teaching, whereby they do student follow-ups in the clinical area. So you can see that they are overwhelmed by the work they do. So the aim of our paper is to assess the readiness of 4 private nursing education institutions in Lesotho to fully implement simulation-based education. And also we want to describe the facilitators and barriers to the implementation of simulation-based education. The methodology that we followed, it was a quantitative, descriptive, whereby 63 nurse educators from those private nursing education institutions participated. So we used SPSS version 27 in our data analysis. And then Pearson chi-square, we used it to assess the relationship between variables of interest. And on the results sections, so the level of readiness, it can be graded from slightly ready, moderately, and above ready. So they were moderately ready, all of them, the 4 institutions, they were moderately ready to implement simulation-based education, even though simulation-based education in Lesotho has been incepted in 2012. So there were facilitators and barriers to their readiness, because the questionnaire assessed their readiness to implement simulation-based education. And one of the facilitators to readiness was that the nurse educators found that they need to integrate simulation into the curriculum. They verbalized that. And when they integrate the simulation into the curriculum, now they will be able to produce competent nurses. One of the facilitators was that there were individuals with strong positive attitudes on SBE, which is simulation. They liked simulation so much. They were telling stories that during our trainings, then we had chance to be exposed to simulation. And they also believed that this is the right time to implement simulation. But then there were barriers too. And those barriers are as follows. There was lack of communication from administrators or management specifically on clear strategic vision of SB. Within the institution's strategic plan, there was no component on simulation. And that implies that there was no written commitment by managers that they will support simulation, as in the curriculum, there is little that talks about simulation. And one of the barriers was lack of funding. As you know, Lesotho is a country classified under resource limited setting. Funding was a challenge in implementing simulation. And the p-value showed that when managers provided support to implementation of simulation, the nurse educators become more ready to implement simulation and also integrate simulation into the curriculum. The other barrier was lack of trained simulations to mentor others. As I said earlier on the problem statement, that there is a lack of capacity. So one of the barriers was lack of trained simulationists to mentor other colleagues. In conclusion, colleagues, this study highlighted the level of readiness of the nursing education institutions in Lesotho and also described the facilitators. And some of the facilitators were individuals with strong positive attitudes. They liked simulation so much, but managerial or administrative support and lack of findings are the major barriers. So how do we go forward to overcome this? We are currently developing a model that is going to guide implementation of simulation-based education in a resource-limited settings. And maybe the findings of that model can be applicable to other settings or can be transferred or generalized to other resource settings. We would like to thank the nursing education institutions for providing us chance to collect data to them and also the nurse educators. Frank, thank you so much.
Thank you so much, Solomon, for your nice presentation. And it really a good presentation that now you are discussing about involving the simulation into the basic nursing education, and hoping that this will ensure competence in nursing despite of few available skills lab. Thank you so much, Solomon. So may I move to Lirosha?
Yes, I'm here.
Okay, the ground is yours.
Thank you. Can you see my screen?
Yes, but you may enlighten it, yes.
Okay, okay. Greetings to Rogathe, Machange, the chairs and the audience, and a big congratulations to all the presenters on your amazing research. I am Lirosha Moodley, a practicing pharmacist in South Africa and a postgrad student at the University of KwaZulu-Natal. I would like to thank Free Health for the warm welcome and affording me the incredible opportunity of presenting my research at this symposium. In this poster presentation, I will be discussing my research on perspectives on budget considerations for pharmaceutical expenditure in South Africa. South Africa faces challenges of inequity in healthcare, a heavy burden of disease, and an increased demand for medicines with limited funds. These challenges called for efficient budgeting for medicines to cater to the population's needs. This research aimed to determine perceptions from pharmaceutical stakeholders on how the healthcare budget is translated into pharmaceutical expenditure for medicines provision. Achieving this aim will allow documentation of the budgeting process and discovery of deficiencies and shortfalls, if any. This will ultimately achieve the main aim of this research, to strengthen health systems and promote continued progress in health financing. Currently, there are no reported studies investigating how the budget for healthcare is translated into pharmaceutical expenditure in South Africa. This research was conducted using qualitative, semi-structured interviews guided by a discussion guide with 7 pharmaceutical officials involved in the budget and resource allocation process in South Africa. Interviews were conducted between October 2019 and March 2020 and were recorded and transcribed verbatim. Once the interviews were coded by the first author, they were verified by my fellow authors. Thereafter, data was thematically analyzed. This study depicted the knowledge and participation of pharmaceutical services in the budget process. The national and provincial departments of health have improved pharmaceutical budgeting by making strides towards a collaborative, informed, and more evidence-based approach. Pharmaceutical services have roles in advising on requirements, commenting where necessary, constantly monitoring, and taking accountability for their budget. The main considerations that determined the budget included population size and growth, historical expenditure, the extra heavy burden of disease and incidence rate, demand data, and forecasting. The local and provincial pharmacy and therapeutics committee also play a vital role in monitoring and reviewing the budget and expenditure, ensuring adherence to guidelines, identifying high usage and expenditure items, controlling the extent to which non-essential medicine list items are used, advising accordingly, and various pharmacoeconomic analysis to assist with pharmaceutical budget and expenditure. Interestingly enough, when I conducted the interviews, changes were currently taking place on how pharmaceuticals were budgeted for. Budgeting was no longer based on only historical values with added inflation. A more evidence-based process is being implemented. Processes utilizing forecasting tools and consumption-based data are being enriched by real users such as pharmaceutical personnel. The mixed model includes a zero-based calculation, which focuses on real requirements. In April 2020, a ring-fence budgeting for pharmaceuticals was introduced, which prioritized funds for medicines to ensure their availability. Given that South Africa suffers from a heavy burden of disease, the extra heavy burden of diseases such as TB, the expanded immunization program, and HIV and AIDS programs are considered. These programs are given special funding from the National Department of Health called conditional grants. The National Standard Treatment Guideline, an essential medicine list used in public healthcare in South Africa, is a guide used by health professions to support rational medicine use. This tool is the main guiding principle when it comes to pharmaceutical expenditure, as it guides the prescription and consumption of medicines. This process is well controlled and monitored by the Pharmaceutical Therapeutics Committee. This was the first study to report on the decision and thought processes of the healthcare budget and its translation into pharmaceutical expenditure for medicine provision in South Africa. Many complex factors that are interdependent are considered to inform the budget to ensure the population of South Africa receive the medicines they require. I'd like to gratefully acknowledge SAMRC for the research opportunity and the bursary that supported funding for this research. And a big thank you to all of you here who have taken the time to listen.
Thank you so much, Lirosha, for your nice presentation. And you will keep the time and hope the content is full covered. Thank you so much.
Thank you.
Yeah, now is the time for promise. Yeah, we are running short of time. Promise there, please. Promise Jaja. If Promise is not ready, maybe we can move to Anne.
Okay, I'll just share my screen.
Okay. Can you enlarge a little bit because it's too small?
Is it okay?
Yeah, too small, but too small. Maybe you can, yes. That's fine.
Okay. So good day, Chair and everyone. You're welcome to this poster presentation on the development and implementation of palliative care training in Nigeria, accomplishments and future direction. I'm Anne Ogbena, presenting on behalf of the team. We declare no conflict of interest. This training was made possible by funding from the Mululi Kari Foundation. Palliative care is a holistic approach to patient care, which improves their quality of life by preventing and relieving suffering through early identification, correct assessment, and management of pain and other symptoms. Globally, there is a paucity of palliative care providers and an urgent need for training health professionals. Nigeria currently has only 9 health professionals with formal training in palliative care. A visual palliative care training for health professionals across Nigeria was designed, created, and implemented by the Northwestern University and University of Lagos. We describe the development and impact of this training and partnership with institutions across Nigeria and future directions. The Education in Palliative Care and End of Life program and the African Palliative Care and Hospice Association curricula were adopted to Nigerian context by a multidisciplinary team of 12 health professionals from the Lagos University Teaching Hospital, Nigeria, led by the EPEC director. 3 trainings were planned. We have held 2 already. Training 1 provided fundamental knowledge and skills in palliative care, and it held in November 2020. Training 2 focused on the psychosocial aspects of care, symptom control, and special populations that need palliative care, and that held April 2021 this year. Training 3 will essentially be a train-the-trainer training and is expected to hold September later this year. 2 learning platforms were used, the Moodle Learning Management System for participants only, and Zoom for both faculties and participants. Learning was participatory and interactive. For the training 1, it consisted of 6 modules and 6 plenary sections, and speakers were from Northwestern universities and 5 institutions in Nigeria. The Kirkpatrick's model of evaluation was used for evaluation, and we evaluated reaction, learning, behavior, and results. The tools used included surveys. We had a pre and post survey and daily surveys, knowledge testing, and post-training focus group discussion, both for the faculties and the participants. The program evaluation was conducted by a member of the US team who is a specialist in program evaluation. Duration of the training was 4 hours per day for 3 days. We also provided videos on palliative care scenario demonstrating how to handle different conditions in terms of communication. These were also provided in the learning management systems. Participants had access to these learning materials even between training sections. So our results, we present results of training 1 as the evaluation of training 2 is still ongoing. A total of 35 health professionals attended the training. 70% of them were from teaching hospitals. 75% had no prior training in palliative care, and 71% worked with both adults and children. Majority of those at this training were doctors. 100% of the participants had an increase in confidence level of providing palliative care and will recommend the training to others at the end of the first training. A participant wrote, and I quote, "Training was very educative and impactful. Every healthcare giver should be encouraged to participate in training like this. Currently, we have been able to get the support of LUTH management in starting a palliative care unit in the hospital." This is the hospital that also houses the National Cancer Center. In conclusion, we have had 2 virtual trainings with, in which 35 health professionals in Nigeria have been trained in core competencies of palliative care. We have also been able to form a network of palliative care faculties, both in Nigeria and in Northwestern University. Our next steps include 1, to hold a 3rd training in September 2021. This will focus on training participants to educate their colleagues on basic principles and skills of palliative care that they have learned during this training. We hope that with that, we will be able to expand the field of people who have been trained informally in palliative care. 2, we also want to develop a steering committee and a committee of practice to enable, create a forum for people who have participated to be able to discuss cases they are faced with during their course of work. Thirdly, and which is our ultimate goal, is to establish a palliative care training in LUTH. With this, I want to say thank you for this opportunity to present the poster.
Thank you so much, Anne, for sharing your presentation on how you are planning for development and implementation of palliative care treatment. And from this, we are sure that the palliative care will be improved from nurses to doctors. Not only some specific healthcare providers will be able to provide the palliative care. Thank you so much. And thank you also for keeping the time. So after Anne, may I welcome Evelyn?
Hello. It's Evelyn. Hello.
Hello, hello, Evelyn. Please share your screen.
Yes, I'm sharing.
Okay. Enlarge it a little bit, it's too small.
Okay, thank you. Can you see it now?
Still too small.
It's too small. I've enlarged it.
Oh, okay, yeah, that's fine.
Please put it in presentation mode. Can you please put it in presentation mode? There should be an icon on the far right, below, the lower side, lower on the far right. That
far right.
Slideshow presentation. Lower slideshow.
I'm checking. I can't see it.
Okay, just proceed, sorry.
Oh, thank you so much. Good afternoon to everybody, and greetings to all our chairs and the audience from Malawi. I'm Evelyn Chilemba, teaching in the University of Health Sciences in Malawi. Formerly it was Kamus College of Medicine. I'm presenting part of my project results. The project is called Enhancing Interprofessional Education for HIV Care among pre-licensure and newly qualified healthcare professionals in Malawi. So this is just part of the findings. Background: strengthening HIV education through interprofessional training project was implemented with the aim of building capacity in HIV among healthcare professionals in Malawi. Interprofessional education occurs when students from 2 or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. The WHO framework for action on interprofessional education and collaborative practice links health and education systems to the successful delivery of HIV care. At the core of interprofessional education is the creation of training synergies across healthcare professions. These healthcare professionals are well equipped with collaborative skills, and these are required for today's complex healthcare environments. Despite that, best practices for translating interprofessional education into interprofessional practice and team-based care are not well defined. Emerging trends in IP strategies reports successes in collaborative practice. Hence, the integration of interprofessional education approach is a mandate in dealing with HIV chronicity among populations in Malawi. Methods that were implemented: we had a series of 8 workshops, which were taking about 2 days. And these were guided by case-based modules, which were designed by experts. In total, there were 17 modules, and we only used 4 modules to teach the pre-licensure and the new graduates. And these modules, which we had identified, was Module 1, Initiation of ART, Module 3, Comorbidities, HIV and TB Management, Module 4, PMTCT, and Module 17, Pediatric HIV. In total, we had trained 526 pre-licensure and newly qualified healthcare professionals. Pre-tests and post-tests were used to evaluate improvements in levels of knowledge and confidence for decision-making in practice. And these scores were entered into SPSS, and we had run tables, frequencies, and graphs. Key results. There were some noted improvements in aggregate scores in HIV knowledge and clinical confidence among the participants. As you can see in this table, knowledge levels increased significantly among newly qualified healthcare professionals, where greater improvements in knowledge among women were noted than in men. And mostly, the female aggregate scores in all the modules was 10.7. The clinical confidence levels again had increased, as depicted in table 2. And of course, they were higher in newly qualified nurses and allied healthcare professionals. In conclusion, I can say, interprofessional education has significance in educating healthcare professionals in the 21st century, because interprofessional education promotes collaborative practice, and this should be a norm in healthcare education. To achieve the goal of achieving positive healthcare outcomes, we need to change the way we train our health care professionals, the way we train issues of attitudes, and even our health systems should accommodate interprofessional approach. And there is need indeed to revisit our educational curricula if indeed we can operationalize healthcare interprofessional education. We need to identify and support interprofessional education and collaborative practice in Malawi so that we can attain the positive HIV care outcomes among our patients. I thank you so much for your attention. Thank you.
Thank you so much, Evelyn, for your nice presentation. And I wish if we could have more time, we could have more discussion on these poster presentations. But because of time, maybe let me check if Promise is there to present her poster. Is Promise in, or we can proceed with, maybe you can have 2 minutes question, but we still have some question on the question and answer box. So I've seen the question that is directed to Anne. So Anne could respond on the question on the question and answer box. So may I welcome members in case of any question or need clarification or there's any comment.
Am I to answer now?
Yes, you may use this opportunity because there's no one who is asking the question.
Okay, thanks Elsie for your question. Yes, the participants will have will be given certificates, but that is going to be at the end of the 3rd training, because initially the training was supposed to be physical, a 1-week training, but because of the COVID, we had to go virtual. So that's why we have 3 trainings. So at the end of the 3rd training, they will all be given certificates. For your second questions, currently now, only 2 undergraduate institutions have palliative care integrated into their medical students curriculum. That is the only one that we know of that has a palliative care integrated into its curriculum. I also know that one of the tertiary universities, that's the University of Ilorin, is in the process of starting a palliative care and postgraduate diploma. It's been approved, but it has not yet commenced. So that is the state we are in terms of formal palliative care training in Nigeria. Thank you.
Okay, thank you, Anne. I've been informed that Promise is trying to connect that can present his work. So may I ask you to let Promise share his work with us before ending up the session. Please, Promise. Hello, is Promise in, or we can wind up the session?
Yes, while we're still waiting for Promise, there was a question from Professor Abigail Kazembe on the chat box about can we give the list of schools that train simulators and at what level are they trained? Can I please respond on that?
Okay, you may. Please go ahead.
Yes, I try to understand the question, but in a nutshell, we have the nursing education institutions that are using simulation as one of their teaching methodologies, and specifically clinical teaching methodologies. And the exit level of this training nursing education institutions, they all offer diploma in nursing and also diploma in midwifery. Thank you, Frank.
Okay, thank you members for taking your time to join this breakout session, and for the panelists for sharing their posts. So maybe before winding up the session, we'll be having housekeeping announcements, but we are required for the panelists to turn on their videos for the media to take the screenshot. So all the presenters, all presenters, media, if we are done with the screenshot, will let us know. We will continue with the housekeeping and announcements. So at this, moderators for in-housing announcement, if any, or the organizers for announcements. Any announcements from the organizers? Okay, thank you all for your time. Hello?
Rogathe? So thank you very much.
Yes,
so,
please go ahead.
Yeah, we'll be starting plenary 4 at 2:30 GMT. So Rogathe, we will be sending the links for plenary 4 in a little while. We'll be closing down this link, which has just ended. Thank you.